Welcome to the 11th UNC Water and Health Conference. It's a strange year, and I regret not being able to see all of you in person in the halls of the Friday Center, especially in the lunch line. That said, we've got an amazing program, a great set of speakers, and a ton of online content that I know will both inform and challenge you. So settle in at home, in the office, or on the beach, with your mask on, of course, and join us as we interrogate the science to improve global health and achieve universal access to safe drinking water, sanitation, and hygiene. Welcome again, and see you online.
I'm Jennifer Sarah, the Global Director for Water at the World Bank, based in Washington, D.C. I'd like to give you a very warm welcome to the 2020 UNC Water and Health Conference. I've been attending this conference for many years, and I just love it, because this is a conference where academics and practitioners come together and formulate evidence-based policy, which we can bring to many of the countries where the World Bank works.
Hi, my name is Jan Willem Rosenboom, and I'm based in Seattle with the Bill and Melinda Gates Foundation there. Welcome to the 2020 UNC Water and Health Conference in virtual format this year. I have attended this one right from the first time there was a conference, and I'm really looking forward to this one, particularly to the session on anti-discrimination and inclusion later in the week. See you there.
Hi, everybody. My name is Tim Julian. I'm at EWAG in sunny Switzerland. Welcome to the 2020 UNC Water and Health Conference. It's all virtual this year, very exciting. But I'll take the opportunity to plug or promote our event Tuesday, 10:30, room 2, on transformative wash, some work from Johns Hopkins on a mobile health program, and our work on drinking water chlorination and antimicrobial resistance. Hope to see you there.
My name is Vida Duti from IRC Ghana. I'm joining the event from Accra, Ghana. I look forward to meeting my friends and colleagues in the water sector. I welcome you to this event in my local language, Akwaba.
Everyone, my name is Pirom Kov. I'm working with the World Bank in Phnom Penh, Cambodia. And welcome to the 2020 UNC Water and Health Conference. I have attended the conference back in 2012, so I'm really looking forward to this conference again. What I'm most excited for during this conference is the verbal presentation around economy, finance, and policy.
Hello, I'm Pete Kolsky, and I'm with the Water Institute here in Chapel Hill, North Carolina. Welcome to the 2020 Water and Health Conference. And I hope next time you can join us here in Chapel Hill and maybe join me for a walk in the lovely woods surrounding us. I've been to 90 of these events in the past and have enjoyed every single one of them as a chance to see old friends, make new ones, and learn something from the vast range of sessions and discussions during the week. This year I'll be paying particular attention to the sessions on sanitation, but I'll be keeping my eyes open for the other sessions too. Glad you could join us to learn and share.
Hello to all. I'm Julia Rosenbaum from FHI 360, joining this year's conference from Washington, D.C. One of the things I'm most excited about is our side session called What the Clock. We're looking at how to improve hygienic environments for infants and young children. We'll be featuring poultry poo haiku, as well as riveting presentations and dialogue. So I hope to see you Thursday, 9 a.m. in room 3.
Greetings, fellow 2020 UNC Water and Health Conference participants. My name is Paul Christian Murphy, the National Cholera Response Coordinator for the National Drinking Water and Sanitation Directorate DNEPA in Port-au-Prince, in Haiti's West Department. Bienvenue dans la conférence UNC pour de l'eau avec la santé 2020. Welcome aboard, attendees.
Hi, I'm Ben Tidwell, WASH Research Lead for World Vision, coming to you from Baltimore, Maryland. Welcome to the 2020 UNC Water and Health Conference. This is my third year attending, and this year I'm most excited about hearing from the new and diverse voices who get to attend this virtual conference for the first time.
Hey everybody, Joe Brown here, UNC Chapel Hill. My friend Mr. Poops and I are very much looking forward to attending for the 9th time the UNC Water and Health Conference. We're really looking forward to the COVID-19 session on Monday, so see you there.
Hi, my name's Colleen Naughton, and I'm an assistant professor in civil and environmental engineering at the University of California, Merced in the U.S. Welcome to the 2020 UNC Water and Health Conference. This is my 4th time attending. I'm most excited about a side session I'm co-hosting about ensuring high-income countries meet water and sanitation for all by 2030. I hope you can join our session.
Hi, this is Rick Johnston at WHO. I co-lead the Joint Monitoring Program along with Tom Slaymaker at UNICEF. I've been to every Water and Health conference since they started in 2010, and I'm not going to miss this one just because of coronavirus. We love to share findings from the latest JMP reports at UNC, and this year we'll be presenting our new report on washing schools. Come join us on Tuesday at 9 o'clock in room 2. See you there virtually.
Hello, my name is Dr. Sirajum Monira, Assistant Scientist from ICDDRB, Dhaka, Bangladesh. I am the co-principal investigator of Chobi 7 Wash Intervention M-Health Program. Welcome to the 2020 UNC Water and Health Conference.
On behalf of the Water Institute, I want to welcome all of you to the 2020 UNC Water and Health Conference. My name is Kata Lang, and I am the Director of Programs here at the Water Institute. And it's my pleasure to welcome you, and especially all of the folks who are joining us for the first time virtually. It's been quite a year, and so we're so glad that you've joined us for this exciting week of learning and sharing and networking. We invite you to join us every day live if you can, and catch the recorded sessions for the ones that you need to miss. We have over 3,000 people registered for the conference this week from over 130 countries. And so we really look forward to getting to know new faces and having people contribute. We have over 500 students, 500 faculty and staff, and over 1,100 folks joining us from non-governmental organizations from around the world. I want to encourage you to participate in the side events, attend the poster sessions and the verbal sessions, and all of the presentations. It's great if you can engage with the researchers and the programming folks, interrogate the science and the evidence, and help shape and improve practice and inform policy this week. I want to thank all of you who submitted abstracts for peer review for the verbals and posters, and for the organizations that submitted for side events. You are what makes the conference, and so we're really grateful for all of the high quality proposals that were submitted. We also want to take this time to thank all of our plenary speakers today, and we look forward to the first plenary session that will be sponsored by World Vision. Anyone who's registered for the conference can view all of the plenary sessions as well as connect with any of the participants. If you want to ask a question, go ahead and do that, and also send any of the participants a message. I also want to let you know that we are able to offer French speakers and interpretation today for the plenary sessions as well as the panel session. And so I thank you in advance to our interpretation feature and those who will be offering those services for us today. They will certainly be challenged because I'm not sure how to interpret Julia's session called Poultry Poo Haiku. So our interpreters will be earning their work today. We also wanted to let you know that we'll send you a survey at the end of the week that we hope you will provide feedback for and send back to us. We look forward to hearing your comments and your feedback on the conference this year, and look to always improve it. And so thank you for your support and patience as we move the conference virtually. So again, thanks to all of our sponsors this week and the individuals who supported and made this conference possible. I also want to thank again all of the people who are helping to make this conference happen, which is Island Innovation, DP Planning, and all the folks at the Water Institute. It's my pleasure to have worked with you all, and we look forward to the week ahead. I also want to let people know that you should be tweeting using the hashtag UNC Water and Health. And so make sure that you're visiting our daily announcements and the website every day to get updates and to keep connected with us. And so it is my pleasure now to turn the conference over to the director of the Water Institute, Dr. Erin Salzberg, who's coming to you live from Chapel Hill and will introduce our first plenary. Thank you, Aaron.
Oh, no, thank you, Kata. And it's my pleasure also to welcome everyone to the 2020 Water and Health Conference. So let's get to it. As many of you know, we like to kick the conference off by reviewing the latest scientific evidence on key issues that are driving our sector. The idea is to give all of you the opportunity to interrogate the science and the scientists so that we can better separate fact from fiction and ensure that we're using the best evidence to inform our work in the field. So our opening plenary today is focused on the issue that is dominating all of our daily lives, the SARS-CoV-2 virus and the disease it causes, COVID-19. What we've done is we've assembled some of the leading researchers in the field so that we might better understand the virus and how it might impact the work that we do on drinking water, sanitation, and hygiene. Just a quick note before asking each of the panelists to introduce themselves, a quick reminder, you cannot use the chat function within Zoom. So those of you online who'd like to ask a question, you'll need to use the chat function within Passable. And we did ask for questions in advance, so we'll start with those, but please do submit your questions and we'll get to as many of those as we can. Okay, so let's get started. I'd like to invite the panelists to turn on their cameras and then we'll go around and introduce ourselves. And maybe we'll do that in alphabetical order once we get everybody on screen. And fantastic, great. Well, welcome everyone, and thank you again for taking the time to join us. Maybe let's do a quick round of introductions. I was going to introduce you, but I thought it was better for you to do it so that people could put your faces with you and everything else. So Joe, why don't we start with you?
Sure, my name is Joe Brown. I'm an associate professor at Georgia Tech in Atlanta, and I'm in the process of moving to UNC's Water Institute. So I'll be doing that in about a month's time. So happy to join.
Great, thank you. And Paul?
Yeah, I'm Paul Hunter. I'm professor in medicine at the Norwich Medical School in East Anglia in the UK. I medical doctor specialising in medical microbiology and virology, and all my research is on essentially the epidemiology of infectious diseases, emerging infectious diseases.
Great, and Rosina? You're still muted.
Hi, I'm Rosina Gironès from the University. Oh, sorry. Yes. I'm Rosina Gironès from the University of Barcelona. I'm a professor of specialized in environmental virology and emerging viral infections. Thanks.
Great, Barbara.
Hi, I'm Barbara Marston from the Center for Global Health at CDC in Atlanta. I'm currently the lead of the international task force within CDC's emergency response to the coronavirus. And that means less of a cutting edge researcher, but sort of on top of what is happening programmatically with the response to coronavirus globally.
Great, Maria, sorry.
And my name is Anna Maria de Rode Husman. I'm from the Netherlands. I'm a professor in global change and environmental infectious diseases. My background is in molecular virology, and I also work as a department head at the National Institute for Public Health and Environment.
And last but certainly not least, David.
Yes, I'm David Weber. I'm a professor of medicine pediatrics at the School of Medicine and a professor of epidemiology at the UNC School of Public Health. I'm an infectious disease epidemiologist. I practice adult and pediatric infectious diseases and critical care medicine. And my major interests have been in emerging infections and healthcare associated infections.
So as everyone can see, we've got a great group here, and maybe we'll start with just the basics to make sure we're all kind of on the same page here. David, maybe you can tell us a little bit about what is SARS-CoV-2 and where did it come from?
Certainly. So SARS-CoV-2 is an enveloped RNA virus. It is a coronavirus, and corona means crown. And under the electron microscope, you could see little spikes on the virus, and that's how it received its name. Importantly, there are 4 endemic coronaviruses that cause respiratory diseases that are quite common. In the winter months at my hospital, they cause about 5 to 15% of upper respiratory tract infections that we see with sore throat, cough, runny nose, and can progress to pneumonia. There have been 3 recent epidemic coronaviruses, starting with SARS-CoV-2 in 2003-2004, which started in China, involved roughly 30 countries and about 8,000 people, was a pandemic. I actually, by the way, took care of the 8th and last lab-confirmed case in the United States. That fortunately was controlled just with good public health, physical distancing, mask wearing, quarantine, isolation, and it no longer circulates in humans. MERS, which has been with us since 2012, started in the Middle East and remains there. Ultimately, about 30 countries have had cases. It continues to be endemic, and we're all at risk for transmission there. And then most importantly, SARS-CoV-2, which was first recognized in late December, so it's COVID-19 is the disease. Roughly at the present time, 43 million people worldwide have been infected, with more than 1,150,000 deaths. In the US, the impact here is about 8.6 million people infected, 225,000 deaths. We're 4% of the world's population, but roughly 20% of the cases. All of these coronaviruses have started out as bat viruses and then get transmitted to humans. In some cases, there may be intermediate hosts. In the case of SARS-CoV-2, it is the palm civet, among others, and in case of MERS, it's dromedary camels. All are quite similar in the sense that the infectivity, the rho, is in the range of 3 to 4 roughly, meaning if I'm infected, how many other people I infect on average. The incubation period is from 2 to 14 days, averaging about 5 to 7 days. All are respiratory viruses, although SARS-CoV-2 can affect many other organisms there. And all have had super spreader events, meaning by definition, one person can infect more than 10 others. That's a super spreader person. We also have super spreader events where, because of transmission, many people are infected there. So that's sort of the basics of the coronaviruses.
So David, you mentioned one thing, which is you called this an enveloped virus. Can you talk a little bit about what that actually means and why that's special or not?
So it is special. It means as the virus buds out from a cell, of course, all viruses need to reproduce in other cells, and it picks up some of the host envelope around it. In general, envelope viruses have less survival in the environment than do non-envelope viruses, meaning they'll survive for hours to a few days as opposed to days, weeks, and months. And because they're enveloped, they are the most susceptible of all our usual hierarchy of viruses, bacteria, fungi, to disinfectants and to antiseptics. So things like alcohol within 15 seconds will readily inactivate SARS-CoV-2, and many disinfectants will also be very effective in literally seconds against SARS-CoV-2.
Okay, we'll come back to that in a second, but maybe just look at the group quickly. Is this analogous to anything else that we in the water sector work with commonly, or is this a completely separate entity? Would we compare this to any of the other bacteria or any other viruses that we might have a history with? Paul? Yeah, please.
Not really. I mean, it is, there has been work done in the past on on SARS-1 and about whether that is transmitted through wastewater, and there was at least one event that implicated wastewater for SARS-CoV-1. But probably even with SARS-CoV-1, water supply was never a major transmission pathway for the virus. And so one of the big issues with with SARS-CoV-2 is people are wondering whether or not actually there might be a role for water, particularly wastewater. But I think because we know it's an envelope virus, we do know that envelope viruses are very sensitive to chlorine disinfection. And so any effectively managed and chlorinated drinking water supply would effectively inactivate a SARS-CoV-2 quite quickly. Over.
Okay. Well, we'll come back to that. But what I heard then is that SARS is a unique virus. There really isn't an analog out there except for some of the other coronaviruses that we've dealt with in the past. No, that's helpful to know. You talked a little bit, David, but let me look at Anna Maria, and you can tell us a little bit about how is this virus actually transmitted? How does it go from one person to another? Is this something we should be? What are the different modes of transmission that we need to be paying attention to?
Well, the major route, I think most of us know now, is through being in the vicinity of other people that are infected. And so it will go through droplets, but it may also land on surfaces, which you then touch and then touch your eyes or your nose or your mouth. Or in some cases, as super spreaders were mentioned, there may be airborne transmission for just in just a few cases, but mostly it's the droplets that cause transmission.
Rosina, I mean, I heard this mention of the persistence on surfaces and things like that. Are there other things that we need to be paying attention to when it comes to the transmissibility of this virus, particularly to the environment? You're muted, Rosina.
Still, there is not that much information on that, but we have some data already. We know that could be stable in surfaces for quite a long time, but I don't think it's a careful analysis on how many virus that could be in a surface we catch with our fingers and how many are needed to start an infection in your eye or in your nose. So we have data of survival in surface for several days, could be sometimes quite a lot of days. But still there is not really epidemiological proof that this is a significant transmission route. So we know may happen, but doesn't seem to be a significant transmission route. And when we go to water, that's interesting because we start having also some data on sewage stability. We know that in feces will be very little, could be infectious virus, has been isolated infectious virus from feces, but low concentrations, I mean, you really need to have high concentrated feces, virus in feces to be able to isolate the virus in cell culture. But then, so it looks like most of the virus may not be infectious in feces. So in sewage, we will have less concentration of infectious virus. And then, which is intriguing, is that the stability of the virus in sewage is also quite short, could be like at room temperature, the data available suggests like between 1 and 2 days. But if we go to low temperatures, then the stability of coronavirus is really high. So the stability of coronavirus in wastewater or water at low temperature, at 4 degrees, is really high.
Okay, let me come back. Let's come back to some of those issues because I want to try to move through this sequentially. And you're raising you've put a lot of information out there at once. I mean, at the beginning, you raised this issue of infectivity, and this is something that I think is important for us to be able to separate out. So, because what you said then is that the mere presence of a single virus particle does not mean you catch the disease, correct?
That's correct. Yes, always.
Okay.
Yes.
Okay, so there's this idea of an infectious dose. In other words, whether you're exposed to it from a surface or from a feces or from water or something else. Joe, help me out here. There's something called an infectious dose that we have to be concerned about?
Well, I think it's more about probabilities of infection and dose-response relationships, right? So there's probably not a fixed number of viruses that are going to infect somebody, but we think about a dose-response relationship, and not having one for this virus presents a lot of difficulties when it comes to trying to understand the relative importance of transmission pathways, because on the one hand we don't have this dose-response relationship. But we also have very little data on the infectivity of the virus across pathways. We have lots of RNA data, But since RNA is far more persistent than infectious virus, our understanding of how the virus moves and how it survives in different media is unclear at this point.
Okay, so right now, Paul, I'll get you in a second. We don't have dose response curves then for the presence of the virus, let's say on surfaces or airborne or things like that, as to what level will cause infectivity. Is that?
Yeah, we don't have that. We don't have a dose response relationship for this virus. We have some dose response relationships for similar viruses, but not for this one.
Got it. Paul, you wanted to add to that?
Although we don't have human dose response relationships, we do actually have pretty good tissue culture infectivity relationships. And people have been looking at showing culture positive in various contexts. And there does seem to be quite a high ratio between PCR copies, gene copies, and whether or not a sample will be infectious in tissue cultures. And now this is not an exact transferability to human dose response relationships, but typically what's been found is that you rarely, if ever, find an infectious particle unless you've got more than 10 to the power 5 virus gene copies, and you really got to be getting up to about 10 to the 7 gene copies before you actually see regular 50% infectivity of tissue culture. So it does look like the virus is that you have to have a lot of virus before you get at least tissue culture infective particles.
So Paul, sorry, I'm going to stop you for a quick second because I want to make sure that those of us who don't understand everything you're saying might have a shot at it. When you're mentioning gene copies, you're talking about, let's say, the RNA that we're detecting in many of these places. And so the fact that we may be detecting RNA in a lot of these different environments is not suggestive, unless you have a high number of copies, is not suggestive necessarily that you've got a live infectious virus persisting in that surface or in that water, wherever you were measuring.
Absolutely, absolutely. And you can see this in individual patients. If you follow patients with sequential sampling, you find that people shed, a typical case will shed large amounts of infectious virus round about day 1 and day 2. And from on average, somewhere between 7 days, occasionally longer, and occasionally up to 21 days, but that's unusual. You can continue to culture the virus, so it's still infectious. People, however, can continue to shed virus for days and weeks after that is totally non-culturable. So if we did an ordinary PCR test for the throat swab, it is very difficult on that to say whether or not that person is actually still infectious. And it's one of the reasons why many of us are uneasy about doing screening of asymptomatic individuals, because
it might not indicate the true infectivity potential.
Absolutely non-infectious. And then the interesting thing about water is that actually in stool samples, you seem to get a lot of RNA in stool samples in recovering patients. But it's been very difficult. It has been done, but most people who've tried to culture stool for the coronavirus have been unsuccessful. Although I think there's at least one group that has managed it. And so,
I'm going to come back to that. Hold that thought, Joe. I know you had a point you wanted to add to that last one.
Well, just so I think these ratios, which are rather extreme, between the copy numbers of the viral RNA and the tissue culture infectious dose, those are mainly from clinical samples. So for environmental samples, those ratios might be even far more extreme.
Got it.
So all of this sort of underpins, our unease with taking, RNA of the virus from environmental media and saying anything about the risk of exposure. So we just really urge caution on that.
Got it. And Anna Maria, did you want to add to that?
Yes, I think that the large problem with doing the infectivity studies is that you need a high biosafety level in your laboratory. So few studies have been done, but recent studies have shown that colonic fluids actually inhibit the virus. And so that means there's a logical explanation why few viruses would be infectious in stool.
Okay, I'm going to come back to that in a second. David, can I ask you a slightly different question, one more time related to infectivity? Do all people, when they get infected, react the same way, or does genotype or phenotype of the host somehow affect the disease or the magnitude of disease, the ability to catch it or spread it or anything else? I mean, could we expect variations among different populations? Is that something that might happen? You're muted, David, sorry.
We know that about 40% of people, roughly, but the studies go from 1 to 80% of people are asymptomatic. Of those who do develop symptoms, and we do have good data on that, roughly 80% have mild disease, don't come into the hospital. 15% have severe disease, usually pneumonia, and they get admitted, and 5% have critical disease and often multi-organ disease. Many things affect that. Certainly age is the primary factor there. Someone who is age 50, for instance, has 100 times the risk of being sick enough to die, and if compared to a 20-year-old, and somebody who's 100 compared to a 50-year-old has another 100-fold risk of dying, meaning there is a 10,000-fold difference between a 20-year-old and a 100-year-old in the risk of dying. Comorbidities, particularly things like obesity, as an example, diabetes, immune suppression for organ transplant, give you a higher risk of becoming ill, and if you become ill, a higher risk of dying. Health disparities are very important. We know in the United States that African Americans and even to a larger extent Latinos are more likely to become ill. Health disparities, including male over female, have been found in other parts of the world, but depend on obviously the ethnicity and racial groups there. So all of those are just some of those factors. I do want to make one more comment on what we've been discussing. Because this virus does require a biosafety level 3, much of the data we have about transmissibility, environmental contamination, and wastewater contamination, as was already mentioned, but I really want to emphasize this, is based on finding viral RNA. And we know that people can excrete SARS-CoV-2 RNA for weeks and months, and some people have been excreting it for 90+ days, even though they themselves are not ill. And we know that viral RNA persists in the environment well beyond culturable virus. So much of the data as how often we find environmental contamination is based on RNA, not on culturable virus. And so that is a major limitation as we talk about it. I do want to mention just a couple things quickly about transmission, as was mentioned. Short distance droplets, most important. Now some evidence in the right circumstances, indoor, poor ventilation, very sick people, airflow. It might go 6 or 8 or 9 feet, not just 6 feet. No evidence it goes into adjacent rooms, adjacent floors, out in the corridor, at least in an infectious dose. There, we did talk about fomite transmission. I do want to mention there's also a human to animal transmission, specifically to dogs, cats, tigers, minks have been described. At least one outbreak of mink to human transmission has been described. Most of those animals are mildly ill, but some actually become severely ill. And I suspect if we take human SARS-CoV-2 and inoculate it, as we will, into many animal species, it'll turn out, as do many coronaviruses, to have a broad host range.
David, you mentioned aerosols, and Joe, I know this is something you've been working on as well too. What's the difference between a droplet and aerosol? Is there a difference? Does size matter? And is there particular environments where we see, do people respirate all the same size droplets? I mean, how does this work? I mean, when do we generate the type of aerosols we have to most be concerned about? sorry, Anna Maria is laughing at me, but you know, what's the there?
Yeah, well, I have to give you my personal opinion here. I think this whole idea of droplets and aerosols is quite unscientific, because there's just all sizes, and it's a whole range. So you can have a definition where you cut off and then give it a different name, but actually they're just very small to larger size particles that either may be going to be deposited quite rapidly because they're larger, and when they're smaller, they may be longer around in the air. And I think that's a good point of David on the ventilation, and whether you're indoors or outdoors is very important.
Okay, so let's.
And there's actually two factors. There's the size of the particles, but there's also some people have much more virus in their nasal cavity and in their throat than other people. So that's the other factor that's very important for infectivity.
Okay, so it's very individualistic in many respects, and we shouldn't be making assumptions that every person clearly day one might be different than day 5, might be different than day 10 in terms of their respiration of infectious particles, and the very nature of the disease within themselves might change that dynamic as well. So we shouldn't be treating each person as an identical infectious agent at given points in time, if I understand what you guys are saying. Okay, good, there's some nodding. All right, so I'm beginning to understand some of this. That's a plus. David mentioned that the fact it's an envelope virus, and that in some respects makes this highly labile. Where, we mentioned air as a primary. Do we have to worry? And we've talked a little, Rosina mentioned water, and we've heard a little bit about wastewater. Where does this virus survive? Where would we find an active, live infectious virus, not just RNA? And I know what I've heard is that, we've been testing for RNA. And so when we look in these surfaces, we look in these places, we're looking at RNA. Are we looking for live infectious virus on surfaces in water and in other places? And does it persist? Is it in the dirt? Is it on, does it exist like E. coli? I mean, where does it persist? Let me go to Rosina and then back to Joe.
Yeah, what I was commenting previously was focus on infectious virus, because has been experiments done where they could isolate the infectious virus on the surfaces, and then our discussion has been really interesting, because it's important for the people to find out that even if there are data of infectivity of viruses on surfaces for many days, that does not mean that it's easy for you to get infected from there. So there's two different things. And when I was discussing on sewage, nobody, as far as I know, and you please add the information you may have, nobody has isolated so far infectious viruses from this wastewater. So we are discussing mainly stability in wastewater based on experiments where you add the virus to the water and keep the water in the lab for several days. And then also, again, checking infectivity, because as you said really well, PCR or RNA does not give us a real value for risk assessment. So the viruses is stable in wastewater, let's put it for 1 day, between 1 and 2 days at room temperature. But to me, it's surprising when you go to really low temperatures, like 4 degrees, it seems the coronavirus seems to be able to keep infectious for many, many, many days, like 50 days sometimes, or really, that's not exclusive of SARS-CoV-2. That also happened with other coronavirus. But really, a low temperature could be stable for a long time. That's something we need to.
Okay, so that's an important thing to note, that in cold environments, there may be greater persistence of the virus on surfaces in the environment and in things. Oh, that's important to know. Okay, but I'm going to see if I can make a couple of statements and see then, based on what you guys have been saying, whether or not you agree. There is an unlikely persistence of this virus in water generally, correct? In general. In treated water, because it's got chlorine and things like that, based on what David was saying, odds are you're not going to find any infectious virus in treated water. Okay. On surfaces, we may measure the fact that the virus was there through RNA presence and things like that. But the likelihood of finding infectious virus on a regular surface out in the environment is also very low. Is that correct, Joe?
I mean, some of the studies that have actually used the virus in controlled experiments report, half-life of maybe 2 days on a range of surfaces. Although it, potentially, as Rosina says, you may be able to find culturable virus there for many days. The implications for exposure unclear for that.
Again, because that's a dose issue, right? Because you may have an infectious virus on a pump handle, but the fact is, when you touch that pump handle, just because you're coming into contact with an infectious virus doesn't mean you've necessarily exposed yourself to enough of it to actually get the disease. Is that sorry?
Right. And
okay.
the other thing is that apart from temperature, we know that relative humidity, things like sunlight, lots of other environmental factors could play a role in survival on surfaces, and probably do.
Okay, fantastic. All right, this is helping. Now I'm going to get to sewage in a second, but Barbara, I just want to check in with you quickly because you have a lot of experience dealing with other pathogens in the environment, particularly in the developing world, when we're talking about cholera and HIV/AIDS and all these other things. Are there particular things in terms of the environment that we're looking at in low resource settings that we'd have to be concerned about when we're looking at SARS-CoV-2?
That's an interesting question. I'm not sure. I'm not sure there are particular things. I mean, this virus will be less likely to be found where the sun shines. There are more outdoor, probably better ventilation in some of the lower resource environments. So I'm not sure it's a particularly worse. It might be a better situation. I don't know if I could, since I have the mic, just make one comment about, this whole thing about transmissibility. Or two comments. Maybe we have to stay imaginative because viruses will continue to school us. All pathogens do, and this is new, and we're just learning about it. It puts us in an awkward position programmatically because it's very clear that the droplet transmission is the main route of infection. So it's very easy to know where to prioritize your efforts, but you can't write off the other issues. You can't write off ventilation. You can't write off surface cleaning. And so, for a person that gets infected through one of those routes, they're just as infected as if they'd been infected through droplet exposure. And so it's a mean virus in that context. We know to focus on the person-to-person contact, but I think we can't ignore these other, even if relatively uncommon, potential modes.
Oh, that's a good point. Joe, I could add to that.
Just to underscore, I mean, this, I think people underappreciate how mobile and transmissible viruses are in close environments. And, it's almost never possible to show unambiguously that a certain pathway has caused a specific transmission. And so that sort of that challenge, I think, is an important one when we're trying to retrospectively figure out which pathways are most important in given settings. And that has come out a great deal in the debate around so-called aerosolized transmission, but it applies to other pathways as well.
Great. Paul, do you want to add to that?
Yeah, and I think one of the difficulties, I think, for many people to understand with COVID-19 is that in some ways, it's a very different mindset to something like cholera or typhoid, and where really we want to keep it out of people, and we want to do everything we can to stop people getting infected, sort of zero transmission. I think zero transmission for COVID-19 is never, ever, ever going to happen. I think most infectious disease epidemiologists, including I think the Director General of the WHO, has said that COVID-19 is here to stay. My grandchildren's grandchildren will probably get infected with COVID-19. And until we have, and typically what we've seen in the other human coronaviruses, the other human beta coronaviruses, is that they probably moved into human society, one probably about 100, 150 years ago, one 1600s, and caused a lot of harm, possibly. I mean, this hasn't been proven beyond all doubt, it must be said, but probably at the time caused a lot of harm, and then we've come to live with them, and they just cause the common cold. And I suspect that's what's going to happen with COVID-19, that in 20, 30 years, it will be one of the causes of the common cold. The issue, therefore, is we're not going to stop it spreading. We cannot and we will not ever stop this thing spreading. The issue is trying to actually suppress the spread sufficiently that we can actually cope and manage till the point that we develop not herd immunity, but develop this sort of resistance that comes from having had multiple infections with the virus as we grow up, or indeed multiple immunizations over.
Great, thank you. And I'm going to get Anna Marie and David in a second, but I'm getting questions coming in as well, so I want to try to work some of those into our conversation. But I'm also wondering whether the two of you, when I go to Anna Maria and David, would opine on, is the virus changing? I mean, do we have to be worried about it's becoming more infectious in some way, shape, or form through different mechanisms? Is that something that could actually happen? That is something we're going to have to think about in terms of its impact on the work that we do. Either one of you can answer that. Anna Maria, I know you had another point to follow up on.
I just think it's important in this community of people working in wash, sanitation, and hygiene to point out that working with wastewater, whether it's in a laboratory or working in sewers or near sewage, that it's important to protect yourself. So those protective measures that are already out there because of exposure to other pathogens are important, and they will protect you also from this virus. So there's no need to have additional protective measures, but it's certainly important to remember that working with wastewater can always put you at risk.
Very good to know. I'm going to come back to that point in a second. David, I know you had something to add, and maybe you can comment on this. Is this a virus that's mutating and changing its ability to infect different hosts?
So the answer is yes. There are a number of reports. The virus it's an RNA virus. It mutates fairly easily. There are reports of viral strains that are more transmissible, more infective, but there are not yet reports of viral strains that have higher pathogenicity, that is more likely to cause serious symptoms or death. And I will suspect that the virus will continue to mutate, as do other human RNA viruses there. And yes, it's with us forevermore now, as other past endemic coronaviruses are. Nevertheless, the goal here is to mitigate its transmission, to protect our vulnerable population and not overwhelm hospitals. And really the steps to do that are briefly wearing masks, both on the infectious person and the non-infectious person, hand hygiene, surface disinfection, staying at least 6 feet apart from each other, and outdoor activities are safer than indoor activities. So yes, certainly anyone working with wastewater, even though we've heard finding viable viruses uncommon, needs to use the appropriate protective techniques that we would use in hospitals and laboratories and elsewhere to protect themselves.
I am going to go to the wastewater issue in a second, but we're getting a whole host of questions around environmental conditions that might impact the survivability of the virus. If I'm in air conditioning, is that a greater likelihood that the virus would survive, right? We mentioned in colder environments, you said 4 degrees C. Air conditioning doesn't quite get us to that level, but does air conditioning, sitting in an air conditioned environment, does that mean you might be more susceptible? I suspect because you're in closer proximity and the air might not be circulating as much, you're probably at a greater risk rather than the temperature. Nevertheless, what about UV exposure, sunlight? Are there reasons to explain why we're not seeing the same infectivity rates, let's say that may be the wrong term, why we don't see the same number of people getting the disease in Africa? Why does it seem to be that we're seeing other communities where the transmissibility probably isn't the right word, where the infection rates don't seem to be quite as high? Paul, you want to comment on some of those other environmental factors that might be
Yeah,
impacting?
and it's quite interesting. There's been a lot of debate about the impact of climate and environmental conditions on risk, and a lot of it has been not entirely backed up with a lot of evidence, because there isn't a great deal of evidence in a lot of areas. But I think one issue that we do know, there was a paper from Japan where they looked at the potential for individuals who became infected to spread that infection to their contacts. And you were 18 times more likely to infect a contact if you were indoors than if you were outdoors. And this is one of the reasons why, personally, I think wearing face coverings out of doors is probably not necessary and probably not that good an idea, although indoors is a different issue. The other thing about air conditioning, in the debate about whether aerosols are spreading the disease, early on there was a lot of debate about whether the virus could spread through air conditioning. And some of the and people were talking about the Diamond Princess. Can anybody still remember the Diamond Princess? That was that ship that was in Japan. And a lot of people got infected, and people actually did get ill after the quarantine was implemented and people were in their cabins, and they were blaming the air conditioning for that. When you actually looked at the epidemic curves about the Diamond Princess, none of the passengers became ill later than would have been explainable from an infection picked up before the quarantine. On the other hand, a lot of the crew and staff on the ship did get the infection afterwards, but we know for a fact that many of these people were not actually following basic infection prevention roles at the time, so to blame it on the air conditioning. So, you know, looking at, although people were trying to use the Diamond Princess as a explanatory for as proof of aerosol transmission, actually, if anything, it was the other way around. It proved that, you know, it didn't show aerosol transmission because of the lack of transmission once people were confined to their cabins, even air-conditioned cabins. So yes, environment does play a role, but probably it's more to do with whether or not you are being forced indoors. And when we look at other infections such as influenza, you know, influenza kicks off at a time of year when we're all moving back indoors because the weather's going bad, it's raining more, it's colder, we don't want to be outdoors. And that probably is the main driver of climate, is the forcing people indoors in a way that you know, in the summer you don't see. And in terms of Africa, you know, yes, COVID is transmitting in Africa, and it has transmitted, but not as rapidly as we see in northern latitudes. And it's quite plausible that the explanation of that is that people spend a lot more of their life outdoors, where they are much less likely to transmit the infection, even if they are infected and infectious. Over.
Okay, so all those factors may be playing a role. That being outdoors is a far better thing, a warm environment is a better thing, sunlight is a good thing. Being indoors, in closed environments with lots of other people is a bad thing. Joe, I saw your hand up. Barbara, I saw yours as well. Joe, go ahead.
Just to add to that, it looks like from experimental data that the virus survives better in cool, relatively dry air. So humidity, you know, high humid, high temperature, we know promotes viral inactivation. I would also say that, you know, there have been various attempts to try and use weather data and sort of local temperature and humidity data to see the, to understand whether that has an impact on local transmission dynamics. And for the most part, those, I mean, the analyses are problematic because it does depend on how much time you spend indoors versus outdoors and those kinds of things. But those relationships have overall not borne out very cleanly.
Got it. Very good to know. Barbara, you wanted to add that?
Yeah, so two things on, one is about the Diamond Princess, just to add to what Paul was saying. There was transmission after the quarantine was implemented among the passengers, but it was primarily for people in multi-person cabins, so that maybe one person had already been infected and then subsequently infected another person. The crew themselves, to say that they weren't, there was hardly anything protecting the crew. They were living in quarters together and eating in quarters together. So it's not surprising that there was ongoing transmission among the crew on the Diamond Princess. For Africa, I think in the end, we're going to have to get out the multifactorial stamp. There are so many things that could influence what's going on there. Partly, and I think we have to start with this, we don't necessarily know fully what's going on there. There are shortages of reagents and inadequacies of testing capacity all over the continent that have influenced the apparent epidemiology in Africa. So some of the declines that have been seen recently might just be that they've run out of testing reagents in certain places, but there are lots of other factors too, including the age pyramid being so different in Africa than it is in other places in the world. And that would obviously help to explain why maybe there are fewer serious infections in Africa, but I think age predicts not just your risk of bad outcome from SARS-CoV-2, but also of acquiring transmission. There may be different, underlying rates of exposure to human coronaviruses that impact the epidemiology. There may be influence of other things like other pathogens that are endemic there. So I think there will be a lot of things to untangle to explain, what actually is going on in Africa and then how it compares to other locations.
Well, Barbara, you raised a point that, well, you didn't raise a point, but I'm going to take it a step further, and David may yell at me when I do this, because the idea, we have lots of asymptomatic people, right? And so, some people react to this, by, even if we, let's say, factored out all the other comorbidity factors, would we still end up with variations among different populations that leads us to think that there may be some populations that are more susceptible to getting COVID-19 from the virus versus other populations, and that's something that we should or shouldn't be concerned about. In other words, do some people enjoy a genetic immunity to this that might play into how we respond in certain places? David?
So the answer is there isn't any genetic immunity to this. But there is differences in susceptibility. There's just been some recent data, for instance, certain blood types are more susceptible than others. We talked about the very importance of age. Certainly a healthy person at 15 is much more likely to be asymptomatic than an 80-year-old immunocompromised person. But it's still odds, because we've certainly seen people at our hospital who are 15 and healthy who've come in and been sick, and there are certainly reports of deaths in adolescents and children. So the odds are much lower, but they're not zero. When you infect tens of millions of people, even low odds means large numbers. No, I think the best evidence that we were talking about survivability, clearly this, as do all the other respiratory viruses, survive better at low temperature, low humidity, which is why we see them in the winter. Other factors in the winter, of course, were indoors, which was mentioned, which is a dispersion settling factor, as well as no UV light. And I should also say, being indoors in the winter, we heat our houses, dries out our mucous membranes, probably makes us more susceptible. And the proof of that is we see all of these viruses in the Northern Hemisphere in our winter, and we see them in the Southern Hemisphere in their winter. And on the equator, getting to Africa, we don't see peaks and valleys corresponding to summer and winter. We see the respiratory viruses at low level throughout the year. Because of the physical distancing, mask wearing we've talked about, actually, reports from the Southern Hemisphere winter, just our summer that's over, have had dramatic decreases, by the way, in influenza in Australia, Chile, South Africa, showing the same things that prevent COVID transmission, prevent flu transmission. We'll see how well they work in the United States, given our lack of wearing masks and other factors.
Maybe this goes without saying, but I'll say it anyway, just to be clear, because I don't know everybody who's online. David and others, just a nod. Is it fair to say, I mean, to me, my wife works at NIAID, and so I hear a lot about this virus. and some of the insidious things that the virus can do in specific individuals. Is it fair to say we're really just seeing the tip of the iceberg about how this virus really impacts human physiology and what the long-term impacts might be? And that, this is still a very serious thing that we need to pay close attention to in terms of getting the disease. Paul, I saw your hand up, and then I'll go back to David.
Yeah, I mean, certainly, I think what you're alluding to is something called long COVID, which is almost certainly real. I mean, I think it's too early to be sure exactly what sort of long-term impacts a COVID infection will have. There is some suggestion from the UK that up to 10% of people, even possibly 10% of young people who have had symptomatic COVID can have symptoms for several weeks, indeed many weeks, and possibly many months after their acute illness. So, there is still a lot that we don't know about what the long-term public health impacts of these infections, even in young adults, could be. And to a certain extent, in terms of the ongoing public health impact, it is certainly plausible that the long-term disability from people recovering from COVID might actually outweigh the disease burden from the acute deaths early on. So it is, at the moment, we still don't know how bad an ultimate impact this will have on public health going for decades possibly to come. And so, yeah, it is worrying. And hopefully, as months go on, we will learn how to better diagnose and manage some of these longer term effects, because they are certainly there and they are real, and we don't yet totally fully understand what's causing them and how common they are.
Great, thank you, Paul. David, did you want to add to that?
Yes, I did. Two factors. One, I should say, in the US and much of the rest of the world, the prevalence based on antibodies is something like 10% of the population roughly has been infected. To get the modeling would show to get to so-called herd immunity, very poor term. We're not cows, and the people who have not had it are not immune. I prefer the term community protection, where there are enough people who've had disease to protect others. You have to be at least at 60%, probably 70%, and that still only partially protects them. So we are a long way from really community protection having any role in this virus. We could obviously have tens, hundreds of millions of more cases, millions of more deaths. The other thing I do want to talk about is just a very good point about persistence. One study by the CDC in healthy ambulatory, or people who had mild disease ambulatory, showed that 20 to 30% had symptoms lasting several weeks. There are now half dozen studies looking at sick or hospitalized patients. Up to 20 to 30%, 40% of them will have symptoms that last for at least 90 or 100 days. The older you are, the more comorbidities you have, the sicker you are. All of those are independent predictors of recurrent symptoms. There continued symptoms that you would see with COVID: shortness of breath, cough, not fever, though that should be a tip-off. Something else is going on. Loss of sense of smell and taste. But others, in terms of mental confusion, anxiety, depression, not getting back to your normal health, is quite common. And for that reason, the medical center here is forming a post-COVID care clinic. It'll be up and running in January, run by our physical medicine and rehab physicians, with the ability then to look at those patients and send them on to cardiology, psychiatry, and others. And as was mentioned, one of the big concerns is MRI shows that even healthy young people who have been mildly symptomatic or asymptomatic, 10% or so, may have ongoing evidence of inflammation in the heart. And so one of the recommendations is people wait at least 2 weeks after illness, young people, before exercising strenuously. And those that are going to go contact sports or exercise strenuous probably should have an evaluation, a medical evaluation before doing that. The worry is about arrhythmias, irregular beating of the heart, and sudden death as a possibility that we occasionally have seen in other diseases with athletes, although not described with this disease.
Okay, thank you. So this is a very complicated disease that we're just at the beginning, I think, of fully understanding of how it impacts human beings and the interaction. Paul, I'll turn to you for a second, but I do want to get to wastewater, and I want to make sure we have time talking about
I just want to come back on this issue of herd immunity. Herd immunity works really well when you've got long-term life immunity. I think the evidence at the moment is that that isn't going to happen. So by the time you've infected 70% of the population, the first half of those are probably susceptible and can transmit the infection again. And we know this to be a fact because with the other beta coronaviruses, the two other human beta coronaviruses, they can cause infections in the same people every second year. And so I think herd immunity from natural infection isn't really going to happen. Over.
Right. So to put that in normal terms for the rest of us humans, normally when we get sick, we assume that once we've developed antibodies to that particular illness, we're not going to be susceptible to getting it again. I think there's still not a lack of clarity on how long you might develop immunity should you get exposed to SARS-CoV-2 and develop a robust antibody response to that. We don't know whether that's a 4-month immunity or a 2-month immunity or a 10-year immunity. We just don't know whether or not getting
we've seen people who have had second infections with different COVID viruses a matter of 6 or 7 weeks apart. And so it can be very short. Although there have been some descriptions of people getting more severe illness the second time around, generally, I think most of us think probably the second illness won't be as bad as the first, but that's not going to be the case every time that it appears, sadly. Over.
Yeah, so this gets back to Barbara's point about this is not a one-time intervention. We need to be thinking holistically about how we work through these systems to maintain an overall effective strategy to dealing with this. All right, let's tackle this wastewater issue a little bit because Rosina and Anna Maria, Paul, you all mentioned a couple of things, but I want to tease this apart a little bit. The first thing, if you get the virus and the virus lives inside of you, if I remember some of my own reading, it might reproduce in the intestines, but that once it hits the colon, by and large, because of its envelope nature and the high acidity that exists in these systems, the virus doesn't survive the colon very well. And so what we crap out, by and large, may contain large remnants of the virus, RNA and other things that we can PCR to detect, but doesn't contain actual infectious virus. Is that true, or did I go a bridge too far? No one's volunteering to take me on. Joe will. Thanks.
I mean, it has been cultured from feces. That's clear. It's been a handful of cases. It's clear that it's not easy necessarily to get infectious virus in feces. It's never been cultured in wastewater, as Rosina indicated. So it's not, it's not sort of doesn't fall in the same category as our more traditional kind of sanitation related pathogens in that respect.
So when you mean it hasn't been cultured at all in wastewater, when you mean wastewater, you mean feces mixed with urine or in some sort of wastewater process, right? Not just, and the only place where we've been able to find culturable live virus is in the actual solid waste itself.
Right.
That fair? Okay. Is there, and Rosina, if I remember correctly, you were saying while we might have found infectious virus in solid waste, we might not at levels that we would consider to be infectious. So does this group think that exposure to solid waste And I understand we need to have protection, and Barbara, your point's well taken, right? Solid waste is infectious, a whole host of pathogens and everything else exists there, and Musa Mango would be upset with me if I said otherwise. We need to, deal with it in the right precautions. But is there anything special that we need to be thinking about because we might be finding infectious virus in solid waste? Anna Maria?
I'm sorry, I just wanted to come back on how the virus was not cultured from wastewater, because in some instances it has. But the point actually was that there are some inhibiting factors in the colon that just make that there's less infectious virus. So most of the detections will be RNA, will be the genetic material. But there have been instances that it was cultured from wastewater, raw sewage. And to my knowledge, even like 1 or 2 samples of treated sewage, but very rarely, if that answers your question.
Joe, well, hold this. So now you're hang on, you're shedding a little bit of doubt on this. So we've been able to take a sample of wastewater and we've been able to culture a live virus from that sample.
Yes, but very rarely. Yeah. So
Joe?
most of all the samples are negative, but there have been some.
Okay, Joe?
I was just gonna say that's news to me. That's interesting. I'm sure it's possible because obviously it could be present in feces. I would say it's been speculated too that some of the methods we use for looking for viruses in wastewater, in particular the concentration methods, could adversely affect survival of the virus in those matrices as well. So it's possible. It's probably very, very rare if it exists. But there are these other factors that could influence whether we're finding it there or not.
Sorry, Rosina.
Yeah, Ana Maria, that's interesting. Has it been published, the isolation of infectious virus from the wastewater? So it will be nice. Ana Maria, I just was asking you because we said we could ask questions between each other. If it's published, the isolation of the virus from wastewater infectious. Well,
but very, very rarely. So most of all of those are negative. So it's very, very rare. Yeah. And there, but we can discuss that later also. I think what's important maybe to point out is also how urine doesn't seem to play a big role. So when we talk about this virus, we talk mostly about detection in feces and not so much in urine, whereas some viruses are excreted in urine, but that doesn't seem to play a role. But I think more importantly, wastewater, but maybe you want to get to that point, wastewater seems to be a very interesting way of surveillance of what's going on in the human population. But I'm sure much more people want to comment about it.
Yeah, so yeah, let me just add that that because it has been isolation published in feces, we need to always consider, as Ana Maria said before, wastewater as a potential risk, because we know will be low, but you can never say zero. For this reason, protection is important. And also I want to point out that what we commented before, that in cold temperatures, we know that coronavirus could be infectious in wastewater for a long time. So
I mean, so you have to make this simpler for me, right? I mean, do I have to be concerned about fecal waste? Is there enough virus in fecal waste that I need to be taking special precautions in dealing with fecal sludge because of this virus?
Yes, you must be very precautious with fecal waste always, for all viruses.
Okay, so as long as we're then dealing with it in our standard ways and taking the normal sets of precautions, then there is nothing special that we need to be concerned about with fecal sludge in the way we manage it or the way we deal with it.
Not more than the others, yeah.
Okay, sorry, Joe, I know you had something you wanted to add.
Well, I just want to say that we have a side session after this afternoon at 1:15, all about wastewater and SARS-CoV-2. So I really encourage everybody to try to check that out and where we'll cover a lot of this stuff, and should be really interesting.
David, you wanted to add something there?
Yeah, just, there was one outbreak for SARS-CoV-2 in a hotel in Hong Kong that they suggested backups of the sewage system was not working well, and aerosolization of feces led to transmission of SARS-CoV-2. There are really no examples yet, evidence for transmission by flushing toilets and sewage leading to outbreaks for SARS-CoV-2, and so I don't think that's a major concern. I think the biggest issue is the one we already was just briefly mentioned, and I'm sure will be mentioned more today later on, is can you use sewage, much like we did for polio in those days, as a marker for community transmission and as another way of another marker for how much transmission there is. And certainly here we are at the University of North Carolina. Certainly people have done RNA measuring in the wastewater for dorms at other schools, not at our school, as a way of detecting early transmission within dorms. The major limitation, as we've said, is it may be overly sensitive because people can excrete RNA long after they're no longer infectious. Ambulatory humans only stay infectious for about 10 days, but can excrete RNA in stool and frankly in respiratory secretions as well for months.
So David, you said something that I want to tease apart really quickly here. I know we're getting short on time. You mentioned the aerosol transmission from fecal waste and things like that, which if I heard correctly, that's not a risk that we think people should be concerned about. Are there other types of aerosol transmission with this virus that we need to be concerned about, or in general, it's primarily these droplets that people expel, the way they land on surfaces, the way they get transmitted? Is there a different type of aerosol component that we're not touching on here that we need to address?
No, I don't think there's concerns about swimming pools, ocean swimming, other. We did talk about a little bit about surfaces. I will say in terms of expelling the particles, people playing instruments, singing, coughing a lot, the particles go further. So there are some factors, leaving aside all the things we did talk about, indoor air turbulence and others, that do play a role in outbreaks and in risks of transmission.
Okay, so then the aerosolization of the virus through water or through fecal waste or through any of these other things, that's not a likely source of transmission that we need. Okay.
So we need to keep an open mind. We need to do more studies. We need to look for viable virus. And all I can say is the data at the present time does not support this being even a minor mode of transmission. But as with reinfection, we heard just in the last 2 or 3 weeks, there are now a dozen plus reports of reinfection. I'm sure that's the tip of the iceberg based on what we know about other coronaviruses. So I certainly have an open mind, and I think we need to continue doing high quality research.
Okay, I'm going to move to a round robin quickly to talk about how we kill the virus before we go to the next session. But very quickly, is there some myth that you see out there about this virus, something you keep hearing people say that you just wish to heck would go away, that we need to address and kind of nail in this particular session? Is there anything that you see circulating within our community that we need to speak out against at this point? David?
I'll quickly say masks work, masks work, masks work. Despite all the issues of how far it might go, we know if the infected person is wearing a mask, they don't expel a viable virus. That's been studied with non-SARS-CoV-2 coronaviruses with flu. And we know if the non-infected person is wearing a mask, they don't get infected. Those two are additive along with physical distancing. So if I had any take-home message, and despite what people have heard in the US from certain individuals, mask work, physical distancing work to a lesser extent, but also important, hand hygiene, either soap and water or an alcohol-based product of 60 to 90% alcohol and appropriate surface disinfection, but they're less important than wearing masks.
Okay, so let me ask this question then, as it starts to segue. You started to mention hand washing. Does hand washing kill the virus? And
No.
what is it? Okay, thank you. Hand washing does not kill the virus.
It physically removes the virus.
Okay, so it removes the virus. What do we need to do then to either remove or to kill the virus? We're going to be moving to the next couple sessions throughout the day. Sure. We're going to talk about how do we respond to this. What does the science say about how we kill this virus on surfaces, in the air, on our hands? What do we need to be doing?
So alcohol works on our hands because it's soap, and we've studied non-envelope viruses and envelope viruses. Soap and water removes 3 logs. Alcohol kills 3 logs. They're literally seconds. And the CDC has what they call list and help derived from the EPA of many, many disinfectants. Anything essentially listed as a hospital-grade disinfectant will work against this virus. Now, the air is a little trickier. UV lights in the ceiling will kill it, for instance. But again, if we're 7 feet apart and I give a good sneeze, UV lights in the ceiling may not interrupt that short distance transmission there. So there are ways to remove it, like HEPA filtration or UV lights. But again, they have to interrupt that very short distance transmission. And we have not seen data as to proven mechanisms to do that. So I couldn't recommend to a children's school, for instance, a classroom you're worried about, what changes in ventilation you can make in the absence of wearing masks that would prevent transmission.
So David, you said that hand washing removes the virus. If I did this with sand, would I be removing the virus from my hands as well, or is that not a?
That is a good question, and I don't know the answer of that because the sand's going to stick to your hands, so it may get out the virus on the sand, whereas the water is carrying it down into the wastewater stream, and it's getting diluted and ultimately chlorinated before you would re-drink it. So the answer is I just don't know whether something like that would. Certainly just rubbing it on cotton may remove some, but the hands are pretty sticky, that is the oils on our hands, so that's why the soap is really much better than just doing the same thing you did in just running water.
Okay, maybe a quick last round, and I'd like to get a sense from you as to what are the things that we need to be doing to address COVID within our WASH world. So David has kind of given us good background on this, and maybe I'll start. Barbara, it'd be great to hear from you about special things that we need to be thinking about in low resource settings and how we might need to respond to this virus internationally. And then I'll go through the others, but I'd really like to hear from you some last words about what it is that we need to do going forward to deal with this in our WASH world. Barbara, maybe I'll start with you.
So I want to go with the big 3 that aren't specific to the WASH world, but watch your distance, wear your mask, wash your hands. Okay. Actually, washing hands is good for a lot of other things. And if we can take this opportunity to rev that up and see what impact we can have on other diseases, I'd love to see that happen. Same is true about the masks and the distancing. And then I think this, idea of using wastewater surveillance is a pretty intriguing one. There are a lot of challenges to that, but I'll be interested to see what the group comes up with for ways forward with that. A little trickier, I think, in the international setting than say in the US, where we have a better idea of who's in the catchment area for certain sewage streams and things like that. But I think it's an interesting point regardless. But I'd like to see hand washing for a million reasons, COVID just being one of them.
Yeah, and just to be clear, as we go through the others, because you mentioned it and it's come up a number of times, in wastewater, we look at the byproducts of the virus degradation, right? So we're picking up RNA in wastewater, and we're using that to make inferences about what may be levels of infectious virus at a source, maybe inside the community or inside a patient or something like that. So there's still a step removed from then knowing whether or not we're being exposed to a live virus, even if we're detecting large amounts of RNA in our wastewater. But I welcome views on that too as we move forward and we hear about next steps.
And I wasn't trying to imply risk from the wastewater, information from the wastewater. Right.
Perfect. No, I think that's right. I'll do the rest in alphabetical in how you appear on my screen. So maybe Joe first with you, then we'll turn to Paul, and then Anna Maria, and then Rosina for your closing thoughts.
Yeah, I mean, I think I would second a lot of what Barbara said. I mean, a lot of the kind of common sense wash measures that we have are ones that we should double down on. They're effective. Certainly, hand washing is a natural is part of our portfolio, and it absolutely can reduce risk of transmission. I mean, I think in terms of research, I really love all of the activity that's going into wastewater surveillance right now, and I think that we're developing a lot of tools that will end up bearing fruit for other infections and other methods of surveillance later on, and that's really encouraging and interesting. I think there's a lot of work to be done on sorting out environmental transmission and really bringing better data and more experimental studies to understanding how the virus moves in the environment and how people get exposed. But I ultimately think that at the end of that process, our advice is still going to be the same. Stay physically distant, wear masks, and practice basic hygiene.
Joe, David, very quickly, do we have to worry about animal waste? I know that there's something about now some of this transmission to pigs and potentially that being at least some of those viruses being human beings being susceptible to some of that. Do we have to worry about animal waste and livestock?
As I said, this virus has been transmitted to a number of animals. I'm sure in the lab you could probably transmit it to pigs and cows if you use a high enough viral titer. I'm not aware that that has been reported from China, where they have very close association, for instance, with pigs. So at the moment, I would say no, but coronaviruses do have broad host ranges, and there have been, much like we've seen bat to human viruses become endemic, we've seen bat to pig and bat to cow coronaviruses that are now endemic among those as well. I'm not aware we've seen those porcine and cow strains being transmitted to humans. So at the moment, I would say it's purely theoretical.
Great. Paul. You're still muted, sorry.
Yeah, okay. I think to me, one of the best public health messages around COVID has come from the Japanese when they talk about the 3 C's. And it's basically avoid closed spaces, avoid crowded places, and avoid close contact settings. And I think those are the keys to controlling COVID. Yes, face coverings have value, but they do not, a face covering is not 100% guarantee. And you have to, and if you're wearing a face covering and then going into these other areas, then you are still putting yourself at risk. The other thing about face coverings is they've got to be worn properly. A face mask hanging around your chin is not going to do anything. A face covering that is just hanging around the top lip isn't going to do anything. And face coverings that are worn that get wet are probably not going to be doing as much as they could. N95 masks outside of hospitals, I would really discourage people wearing those. But the bottom line is try and follow the 3 C's, and hopefully then you will reduce your chances of getting the infection.
Thank you, Paul. Anna Maria?
Yes, and I think this is also true for people, again, working in WASH. So that's not different than some of the other pathogens. So I would like to point out that there's many good documents by, for instance, CDC, but also by WHO. And specifically, there's this technical guidance document, which is called Water Sanitation, Hygiene and Waste Management for SARS-CoV-2 virus that causes COVID-19. And I think if people want to learn more and want to have some quick advice, then you could go and read that. I think that's all from me. Thank you very much.
It's a perfect segue into the conversation that'll be happening in 15 minutes. So thank you very much. Rosina.
Thank you. I just think that may be useful to add that wastewater surveillance is contributing to monitor the trends of the epidemics, and cost effort. It's cheaper than testing many people, and in many different occasions, it's useful to find out if it's improving or is not, or maybe early warning if you don't do many tests in the population, and will help a lot when all those countries will have no much more money to do more PCRs, or not so much for doing tests. And that could help a lot to follow the evolution of the epidemics. I just wanted to point that out. And we are improving a lot the methods, trying to build models to take out conclusions, which is not easy with the official data that we have now available. But I think something that will help a lot. And the professionals in the water area are very much aware of that. Thanks.
Great. Thank you, Rosina. Thank you to everyone on the panel. I know when we leave, we're going to disband. So I just want to thank all of our panelists for the time and for the great conversation that they gave us today. I think this was truly wonderful. I also want to thank the interpreters. I know they staying over for an extra second, so I appreciate that. A couple of quick announcements for people who are with us. Please do rejoin us in about 15 minutes at 11:45 EDT. For our next COVID-related discussion around the state of the global response. This gets to the exact set of issues that Anna Maria was talking about, and we'll hear from a number of folks who are working to tackle this issue across the globe. I also want to quickly thank all of our sponsors once again and encourage everyone to attend our virtual exhibit hall both today and Wednesday at 3:30 p.m. and visit our sponsor booths. You'll have an opportunity to engage all of them and see everything that they're talking about. And for those of you who will be up late or up early, please join us for the Late Early Show. This is a special program for our Asia, East Asia, and Pacific colleagues where we'll be discussing highlights from the day. The Late Early Show is open to everyone, but you do need to register through the Passable site. So go ahead and do that. So I'll look for everyone back in about 15 minutes. And again, thank you so much to our panelists. It was a great session. I really appreciate your time this morning. Take care. Have a great conference.
You too. Ciao.